Here are the details that every American needs to know about this plan.
Medicare will become law on July 1st, 1966.
I want America to have the finest health care in the world.
This healthcare system of ours is badly broken, and it is time to fix it.
Well, we spend $2.7 trillion every year on healthcare.
Our healthcare is too uncertain and too expensive, too bureaucratic and too wasteful.
This legislation will not fix everything that ails our healthcare system, but it moves us decisively in the right direction.
And we will always protect your Medicare, and we will always protect your Social Security.
This is what change looks like. This is what change looks like.
What is going on, everyone, and welcome to episode number 2 of the State of Healthcare. I am your host, Ned Eric, and today I couldn't be more excited to bring to you guys this interview with John Gorman. It is an absolutely amazing interview with John. I really think that he absolutely, what he and his partner or his group are doing over there at Nightingale Partners is just such an important thing. And I really think that as we actually recorded this on June 9th, and I think really just the volatile nature of what's going on in our country and what they're doing couldn't be more important as really the inequities in our system as a whole just continue to come to a head. And so we talk about the social determinants of health. We talk about different inequities in the system. We really talk about some of the misconceptions as well, social determinants, and a really cool thing that they're doing, a program that they're doing out in Baton Rouge as well as Puerto Rico that I think we're going to see a lot more of in the future here. And he even gives the rundown. I would just call them the John Gorman best practices of how do you get involved. Say you're a physician executive, you're a CEO of a large, Medicare Advantage plan or a physician group, medical practice. How do you get involved in this? And what do you do to navigate this industry, right? What do you do to navigate and make sure that you're making the right changes and you're focusing on the right things? And so I'm super excited to bring John Gorman on. John is just a phenomenal, he was a phenomenal interview, and he's got a phenomenal resume. And I really think that what he and his group over at Nightingale Partners are doing is really revolutionizing healthcare. And just a little bit about John. John is the founder and former executive chairman of Gorman Health Group, which at the time was the industry's leading consulting practice, which spawned almost a dozen entrepreneurial ventures in government healthcare programs. John's work focuses on Medicare, Medicaid, and Affordable Care Act strategy, governance, and turnaround of distressed health plans. Prior to founding the firm, John served as the assistant to the director of healthcare financing administration's Office of Medicare or Office of Managed Care. That's actually CMS today as it stands, where he provided day-to-day management and served as the external liaison for the Medicare and Medicaid managed care programs. During the 1993 debate on national healthcare reform, John was the chief lobbyist of healthcare financing issues for the National Association of Community Health Centers, an organization of federally funded primary care clinics for the medically underserved. John's career in Washington began as the press secretary and staff director for U.S. Representative John Conyers Jr., Democrat out of Michigan. Then chairman of the Government Operations Committee. John has done a ton in his career, and he now serves on the board of directors of Henry Ford Health Systems Health Alliance Plan in his birthplace of Detroit, Michigan, and serves as a senior advisor to Premier Inc., the hospital purchasing cooperative on Medicare Advantage and Medicaid matters. This guy is the one you want to be listening to. And that's why I'm going to shut up and I'm going to let you guys hear this interview. All right. Hey, John, how you doing?
I'm great, Ned. Thanks for having me. How are you?
Absolutely. And I can't complain right now. So definitely good, man. And good. John, man, I really appreciate you being on today, because I think today, as we record this, June 9th, 2020, what you guys are doing at Nightingale Partners is extremely, extremely important.
Thank you.
Because as we sit here recording this, I think a lot of the inequities in our system are coming to a head.
Oh, yeah.
And I don't want to start this podcast with assuming everyone knows what you guys are doing, and then also assuming that people know what social determinants of health are.
Sure.
So how about we start out today and just give us as deep of an overview as what you guys are doing, as well as really where we sit today as an industry on really moving the needle forward with the social aspects of healthcare.
Sure. So yeah, you're exactly right. I mean, this pandemic combined with, all the civic unrest around police brutality and violence and inequities in America really have really laid bare, how deep these inequities go, especially in our healthcare system. Nightingale Partners, our company, Ned, was started to basically help the health insurance and provider industries invest rapidly and significantly in interventions in what we refer to as social determinants of health. Social determinants of health are just basically four fancy words for poverty. And because we do such a crappy job of maintaining our social safety net in this country, I mean, we spend less than 1% of our gross domestic product on our social safety net, like food stamps and Social Security and welfare programs like that, that in effect it falls to health insurers who are 100% at risk for the healthcare costs of their enrolled populations to, in effect, now serve as social service agencies as well, because we now know that these social determinants of health, where people live, what they breathe, what they eat, what they drink, who they live with, the types of institutional racism they suffer over the course of their lifetime, that these social determinants, Ned, are responsible for 60 to 80% of healthcare costs. And that in many respects, your zip code has a hell of a lot more to do with determining your healthcare expenditures than your genetic code.
Wow.
And so when you look at the disadvantaged and medically underserved communities across the United States, that's also where we find overwhelmingly the greatest sources of healthcare expenditures, of impactable or preventable healthcare expenditures. And of course, as what goes with all of these matters in inequality in healthcare, the greatest number of disparities in how services are rendered and the quality of those services when they are received. So we're here basically as an opportunity zone fund to make big investments in social determinant of health interventions with insurers and with local governments. And then our business model is that we share the savings that we help generate from those interventions, and then that's how we repay our investors. We found the Opportunity Zone program suited our purposes perfectly, Ned. And the irony of it is that this was a program that came out of Trump's big tax giveaway bill a couple of years ago.
Yeah.
And so I didn't really think much of it because I think Trump is a complete idiot and a threat to our democracy at its core. But this was actually Cory Booker's program to encourage real estate development in disadvantaged communities. And then last April, the IRS loosened the regulations around how you could use Opportunity Zone money to include not just real estate purchases, but leases, working capital, and to meet the business requirements of a new company in one of the 9,000 designated opportunity zones around the country. And the way the program works is if you invest money in one of these 9,000 disadvantaged communities and you leave it in for at least 10 years, then not only is your initial investment tax-free, but all the proceeds that you make on that investment, Ned, are completely tax-free. So that, as you can imagine, is like catnip for Republican billionaires. And it opened up a gusher of about $6 trillion in available capital. So in effect, what we're doing and what gets me out of bed in the morning with a big smile is we've hacked a Republican billionaire tax shelter to try to improve healthcare for Black and brown people.
Dude, I love the way you explain that. Like, it honestly, like, it gets me excited for what you guys are doing. Yeah. Right. And I think, what really excites me, like when you talk about this, is because opportunity zones, the way that I've always been taught is real estate, right? Like it's, hey, I'm gonna build something on there. I know there's a lot of places. We're in Southwest Florida. There's a lot of land out here that people are building on that are going to have certain, structures on it that are going to help in those opportunity zones, right? Talk to me about, because I know last time that we spoke, we had talked about what you guys are doing in Baton Rouge. And this, when you explained this to me, it got me super excited about what you guys are doing and who you guys are affecting at probably, the most scalable level you can in the healthcare industry that we're in, right?
Baton Rouge is really fascinating. It's the biggest project we're engaged in so far in our short history. Typically our projects are like partnerships with insurers around food security or housing. Baton Rouge is fascinating, Ned, because in Baton Rouge, if you can believe it, we got LSU to give us Memorial Stadium, their old football field, for $1. And Memorial Stadium sits right in West Baton Rouge, which is one of the worst urban medically underserved communities in the country. And their rate of access to primary care is 1/6 of what it is in the national average. I mean, there's one primary care physician per almost 7,000 residents of West Baton Rouge. So it's a healthcare desert. So what we've done is we're going to take this facility and convert it into an integrated community health pavilion, where we're going to renovate all of the athletic fields so that the kids have some place to come and play and be active. But we're going to put on a 100,000 square foot medical pavilion that will have primary care as a tent pole, but then we'll also have an urgent care that'll be open 24/7. We'll have a community pharmacy. We're going to have a hub for community health workers who we're going to train through LSU's School of Social Work. And we're going to have a multi-generational adult and child daycare and a big food security depot that will include a greengrocer, pop-up, farmers markets on a daily basis, and then a large commercial kitchen that will enable us to go and do meal preparation and delivery for homebound, chronically ill people within the West Baton Rouge community. And so we're hoping to use the athletic fields and facilities as a magnet for the foot traffic to come into the pavilion. And then as parents come in to pick up the kids after they're done playing, hopefully they'll use the primary care assets as well as the pharmacy. The adult and child daycare has been shown time and again to just be a great healthcare saver for, especially for the elders that use those facilities as an alternative to nursing homes or assisted living. And we've gotten the partnership of all of the major Medicaid plans in Baton Rouge, including United, Aetna, and the Blues of Louisiana. So we're hoping this is going to be a model for, redesignating public use facilities into community health assets that can really, help us deal with some of the inequities in local health systems. It's not our typical social determinant intervention because this is, when you build a facility like this, it's really kind of a pull strategy. You're trying to pull people to the facility. We tend to really like our interventions for really low income and very sick populations to be more of a push strategy where we're bringing the care and the interventions to them. But it's this one is just, the need is so great there. And the opportunity was just so ridiculous. I mean, how often do you get, a 60,000 seat stadium just given to you? We've been really encouraged by FEMA's coming in with 14 million in redevelopment money. The state Department of Economic Development is coming in with another 16 million of their own money. So that's a really exciting project, but far from the typical kind of investments that we're getting into these days.
Yeah, that one, when we talked last time, I was like, dang, man, because, one could ask, hey, where are you getting the funds for this? But it's like, well, you probably pulled the dollar out of your back pocket to get Memorial.
Yeah, I mean, that was easy. That was easy.
And so this is all being done through the Opportunity Zone Fund?
Yes.
Very cool.
And we'll probably end up, all told, it'll probably be a $200 to $220 million enterprise here once we get this thing set up. So it's really a huge undertaking, but it being in Baton Rouge, the capital, that LSU is so intimately involved, the donor community is really coming together around this thing, and we don't think we're going to have any trouble raising that amount for it at all.
Very cool. Very cool. And you talked about go ahead.
On a smaller scale, we have something similar going in San Juan, Puerto Rico, where we're working with boys clubs and girls clubs of Puerto Rico, and they've found an abandoned 3-building complex in the middle of one of San Juan's biggest and most notorious public housing projects. And we're going to renovate this 3-building facility to include a charter school, a workforce development center, where we'll be doing all kinds of job creation and training largely around healthcare jobs. So community health workers, contact tracers for COVID, pharmacy assistants, and the like. And then the 3rd building will be the Health and Social Services Pavilion. And it'll be sort of like what we're doing in Baton Rouge on a smaller scale, with a much greater emphasis around behavioral health because of the needs of this public housing community that we're going into with that facility. That's going to be about on the other end of the spectrum, that's about a $15 million project there, because the property is so much smaller and the cost of redevelopment in Puerto Rico are so much lower.
Yeah. There's something I want to double click into is you talked about food security multiple times, and I almost feel dumb saying this. It feels like this is sort of an obvious statement, but food insecurity, I believe it's like 34 million people that are on Medicare Advantage are food insecure. And it's like $51 billion in like resources that we're spending that we don't need to. It almost seems obvious to say like, hey, if I'm worried, and really with all the social determinants of health, if I'm worried about where my next meal is coming from, if I'm worried about how I'm getting to the doctor, or if I'm going to have a roof over my head tonight, it makes sense that I'm probably not going to be as compliant as the guy in a different zip code who has a nice car, a nice house, a family, right? Why, I'd love for you to go into some of the stats a little bit more, because I know there's some great case studies that you've talked about where literally all these plans have done is given a food option to people to provide them with healthy food, and they have saved tons of money. And it seems almost, why is this not the norm right now from not only like a moral standpoint of like, hey, it's another human being, they need their food, but also a financial standpoint?
Right. Well, I mean, food security is one of the most meaningful interventions that you can have in social determinant interventions. Typically, these types of interventions yield a 3 to 8x reliable return on investment. Food security, and as we get this growing awareness, Ned, of food as medicine, especially for chronically ill populations like diabetics or those with chronic kidney disease, medically appropriate meals are some of the best medicine that we can offer. And it's so simple and so cost effective that these interventions just typically yield incredible results. I mean, we cannot lose sight of the fact, especially now in the middle of a recession brought about by this pandemic. As it was before this pandemic, 1 in 5 Americans went hungry on a regular basis. And as we all know, in healthcare and social science, we've got the doctrine that we refer to as Maslow's hierarchy, right? And it's basically when you look at the the hierarchy of human needs, and among those most basic human needs is needs for shelter, safety, and food. And that until those basic human needs are met, nobody is going to be thinking about, did I take my insulin right today?
Yeah.
They're thinking about, where is my next meal or my next bed going to come from? So dealing with food security really is the bedrock of any real intervention in social determinants. And the most landmark study we've ever seen came out of Geisinger in Pennsylvania, the huge and really incredible rural health system in central Pennsylvania. They found a couple of years ago, Ned, that they were spending almost $300,000 per patient per year on their uncontrolled diabetic seniors that they had enrolled in their health plan. So they started a medically appropriate meal delivery program for them. And within 14 months, they dropped that average cost to $48,000 per patient per year. So net of the cost of the meal preparation, packaging, and delivery, they saved almost $192,000 per patient per year. That was a 35x ROI. And to an investor like me, I mean, Jesus, Ned, I mean, it doesn't get any better than that. You don't see 35x ROIs anywhere. No. And when you can do it that simply through just feeding people, those are the kinds of bets that we want to place all day long. And really goes to show that if health plans can get out of the mindset of just being bill payers and really start to think more upstream in terms of very cost effectively meeting basic human needs that dramatically impact healthcare expenditures, this is the way that we bend the curve in what we're spending in Medicare, in Medicaid, and in the individual commercial markets in particular, because this is where all the cost is among people with these, these chronic conditions and comorbidities that are really easily preventable through these relatively simple interventions.
Now, is this a policy thing? Like, does the policy need to change to make these like health plans go, all right, it makes sense for us to add these different, benefits?
Yes. I mean, that's one of the reasons that brought us into existence. I mean, notably, 3 years ago, the Center for Medicare and Medicaid Services made a major policy change that allows health plans in Medicare Advantage to now include in their bid benefits like food security or housing subsidies or home improvements, and to include that as a covered benefit. The problem, Ned, was that they didn't include any new money to help pay for these new benefits. And so the jam that the health plans then get into is, one, if they use their own money, let's say we're going to pay out of our own pockets here at XYZ Health Plan to house these 10,000 homeless seniors that we've enrolled, then that means their actuaries will then tell them, well, that's going to mean we have an $8 increase per member per month to premium. And most Medicare Advantage plans now compete on the basis of a zero premium net. So none of them are going to, decimate their competitive position in a zero premium market by saying, yes, we're going to go and house these 10,000 people and have to jack our premium to $8 a month. That's where we come in. So we bring in external third-party Republican billionaire capital. We design, these interventions for them, and to the extent that they need us to execute and actually run these interventions for them, we can do that as well. But then that will then save so much money a couple of years from now. And then we split those savings with them to repay our investors and then to plow back into the program to continually expand the number of people that we're serving. So those types of interventions tend to yield the greatest results. I mean, we've talked about food security. Housing security has consistently shown to save thousands of dollars per member per year across all demographics and income strata and geographic markets. some of the most pronounced findings have been in New York City, but then also in Los Angeles, where Los Angeles did a great study that showed that homeless individuals in Los Angeles County on Medicaid cost taxpayers 80% less if they were provided with transitional, supportive, or affordable housing. So, I mean, this stuff works as investments. Plans just have to think a little more globally about the fact that we are now de facto social service agencies if we are 100% at risk for the cost of our population.
Yeah. And what you're saying all makes sense, right? Like, it's not like what we're saying here, it shouldn't seem revolutionary, right? Like, I think we're at where we're sitting here going, well, giving people basic needs met is going to help us be able to take care of them, right? I think it's one of those things where if I know that someone has an address, I know where we're going to drop off this food, right? Like, it all makes sense. But as the CEO of a health plan going, oh, I now have to lose my competitive advantage. How do I navigate that? Like, obviously it's reach out to Nightingale Partners, right? Like, it's get them involved and get into these opportunity zone funds and that. But if I'm sitting here, I'm a CEO of a Medicare Advantage plan, I'm saying, how do I navigate this? It is one of the most important things that we're talking about as an industry today, right now. How do I navigate this and make sure that today, moving forward, my benefits are all set for 2020, right? How do I make sure that I'm focusing on the right things?
Well, I mean, the first thing is you have to understand intimately the needs of your enrolled population. I mean, you can never know enough about the people that you're serving. And frankly, the risk profile of those folks, not just from a clinical standpoint, Ned, because you can look at all kinds of medical and pharmaceutical claims data and get a pretty robust picture of the membership. But when you look beyond and you look at what their non-clinical needs are, what their social needs are, that's the X factors that contributed to the demise of disease management in the 90s and why population health is doomed to fail unless it begins to factor in social determinants and the non-clinical needs of its populations. I mean, you cannot manage a disease state in a vacuum. You just can't say, okay, we're going to go and manage diabetes unless you intimately understand, this beneficiary, Mrs. Ramirez, with uncontrolled diabetes, lives in a food desert. There isn't a grocery store around for miles. The best she can do is the local bodega where she can get a can of condensed soup that's so loaded up with sodium that if she has that soup, it's going to interact badly with her diabetes and with her congestive heart failure, and she's going to end up in the hospital that afternoon because she can't go to a decent grocery store to get food that won't kill her. So it's, what we always do in our process is to first run all of the data that we can get our hands on. We developed our own proprietary technology that bangs up against 2,000 different publicly available sources that looks at housing stock, that looks at income status, that looks at water quality, air quality in all of these communities, and gives us, when you combine it with the medical and drug claims data from the plan that we're working with, enables us to hotspot where the communities most at risk are, all the way down to individuals and their households, so that we can now see what their social risk profile is. And this is particularly helpful in the context of this pandemic, because, we're asking seniors and chronically ill people, basically to shelter in place and to basically isolate themselves over an extended period of time. To be able to do that safely and effectively, especially with seniors and the disabled, we really need to understand, are they in a fourth floor walk up? Are they in effect homebound? They can't get out of that apartment. Are they living in a damp basement and they have asthma and COPD and, they just need $500 worth of mold abatement and they'll be able to stay in that apartment safely for as long as this lockdown entails. These are all critical data points that go into designing an intervention that will ensure we're putting the greatest amount of investment dollars and resources to the people and the communities that need it the most, so that we'll have the greatest impact and savings later.
So it's really actually understanding your panel beyond like the person that walks through the door. And what you're saying there, it makes the sense that it makes is the reason that I think that we are obviously moving, we're moving away from fee for service into value-based care, where it is for these plans and these providers, it makes more sense for me to continue with Ms. Ramirez, right? It makes more sense for me to make sure that she has access to these things, because that's how they make their money, right? That's right. And I think that really, when it comes down to it, is, having conversations with our providers who are, for most part, at risk, right? Yep. It makes so much more sense for them to do what like a ChenMed is doing, where they're calling them all of the time and making sure that they're okay. And they've got like a love hotline just to make sure that these people are good. And so I think that it comes to this point. Now, let me ask you, because you have used community health worker quite a bit, and I've heard you talk about that. I think I'd love for you to dig into that, because in my opinion, I don't think that you can just copy paste a fee for service doc into just the social determinants of health. Would that be wrong to assume? Because is that why you have community health workers? Because the thought process a little different?
Community health workers are the linchpin of any successful social determinant intervention, because you're fundamentally talking about services that need to occur outside the four walls of a provider's office or a hospital, right? They need to happen in community settings. And a community health worker, or in Spanish we call them promotores, are basically social workers without the master's degree, who largely come from the communities that they're working in. And their job is to serve as a navigator for really vulnerable, expensive patients who need a lot of both clinical and non-clinical care coordination. So the first job of the community health worker is to sign up one of their panel of patients. The typical community health worker panel is, usually around 100 patients, but then they're stratified based on risk and how much need. So they probably spend 75% of their time on about 25% of their members. And the first order of business is always to sign up those patients for all of the social welfare programs that they may be entitled to. So signing up Mrs. Ramirez for not just Meals on Wheels, but to also get her utility abatement subsidies or housing subsidies, or getting her signed up for food stamps. I mean, those things have dramatic impact. I mean, all the research shows just helping people sign up for those social welfare programs can knock down their annual healthcare costs by $2,000 to $2,500 per member per year. Wow. Then the community health worker's job is to escort the member through the care continuum and to ensure they're making it to all their appointments, that their transportation from their bed to the curb, to the car, to the physician's office and back again is all arranged, that all of their scripts have been written, picked up, and that Mrs. Ramirez knows how and when to take them safely. And they basically serve as the health coach, or the promoter of good health within the household and with the family. And fundamentally, anytime you're talking about in any poverty initiative, Ned, anytime you're talking about addressing social determinants of health, it's fundamentally a very high touch undertaking. Data only gets you so far. Data can help you target where the resources are needed. But beyond that, all of the best interventions really involve a lot of human contact and a lot of coordination done by real live humans.
Yeah. And I grew up in a place that would be considered an opportunity zone. And I can tell you from experience that it's having someone that's a local that is a lot better than having someone come in from the outside, right? There is that tight-knit community. So that having that community health worker is extremely, extremely valuable. Now, you said they're a social worker without the master's. Is this someone that you go in there, say, hey, you're a leader in the community. Can you be this? Do they have
Yes.
certifications? What does that look like?
Yes.
Yeah.
I mean, there are certifications for community health workers, and there is actually a big effort nationally to try to standardize community health worker training nationally. But fundamentally, the work of a community health worker is intensely local, Ned. And so it really does help that they are from the communities in which they're working. And, I tend to think that this is going to be one of those, those rising new jobs of 2020 and beyond for kids that are just coming out of high school, that, these are going to be wonderful opportunities to be, $18 to $25 an hour jobs that can really dramatically help change the way healthcare services are delivered to the most expensive people at the most local level, which is in their home and in their communities, where most of this stuff really needs to be addressed head on, and best done by bright young things that grew up in that neighborhood, know their way around, and are considered influencers in their own communities.
Yeah, I think that's huge. I've heard you talk about it. Dr. David Nash has talked about having like a front line of workers, right?
Yes.
Like, and even like Scott Galloway, who's from NYU, he's a professor at NYU. He's talked about like having a COVID core, where like kids that are taking like a gap year, what they would do is they would stay in their communities, right? And a lot of his stuff has to do with like, exactly. And man, like what you're talking about, it sounds like it sounds like the next wave, the next generation, the thing that needs to be happening in our, in what we're doing. Now, the question that I would have is how do I go out into the community as a health plan? How do I engage with these people to make it to the point where they're going to go, okay, I want to do this? How's that happening?
Well, it depends on the intervention and how you're going about executing on it. Typically, what we like to do, Ned, is, we don't want to reinvent the wheel. And typically there is a very robust underground of community-based organizations that are already out there doing a lot of this good work. But a lot of those are going to be, a half a dozen lovely church ladies in a basement somewhere preparing meals for delivery that night, right? They never considered, how do we scale and modernize what we're doing here in this church basement so that we can do this for 1,000 people? And that's where we come in many of our interventions, is a lot of the work that we're doing, that groups like Unite Us and others are out there that are really trying to build upon this bedrock of community-based and charitable organizations that are out there, and help them scale to serve more people, and eventually to move away from grants and philanthropy and maybe just doing this out of their own goodwill, to more of a value-based reimbursement environment, where they are true vendors that we can knit into what our long-term vision is, Ned, is of a national, what we refer to as a health equity marketplace, which would be a national leasable network of these value-based vendors that provide these social determinant services in a coordinated way. We're a long way from that happening, but it first has to begin by helping those lovely church ladies practice to the top of their capability, and to serve as many people as they want and are able to. And to the extent we reach that peak of their scale, and there's still a lot more need that needs to be addressed, then we'll go and build additional capability to do that. But, first thing is, we want to lift up all the organizations that are out there already doing this. I've been astounded by the breadth and reach of some of the religious organizations that are out there. I mean, we typically think of folks like Catholic Charities and, the various Jewish humanities organizations. But like, I've been astounded by the reach of like the Lutheran Society. Like, the Lutherans have statewide charitable operations that do everything from food security to opioid treatment in 31 states, and have partial operations in another 17 states. And
Wow.
they're already set up doing this as part of their mission of the Lutheran Church are these business missions who are to provide better quality care to vulnerable populations in their communities. And so working with folks like the Lutheran Society to then scale up the capability of their various business missions, that's mother's milk for folks like us.
Yeah. Wow. And this next question is going to be 100% selfish, and I'm totally okay with that for our listeners. I'm listening to this podcast. How do I get involved with Nightingale Partners and what you guys are doing, on the social determinants of health?
Well, recognizing your audience, Ned, is largely physician executives and folks working in large, probably pretty sophisticated medical groups.
Mm-hmm.
Your audience is really a lot closer to this crisis and where the need is, and therefore can be part of the solution more than they may think. I actually find it a lot easier to work with big capitated medical groups on social determinant interventions than it is to work with insurers, because physician groups just tend to be so much closer to the patients and to see the need on a day-to-day basis that insurers are arm's length removed from a lot of those interactions, unless you're like a payvider, like a Kaiser, right?
Yeah.
So the docs groups really tend to know what those needs are, and they're also a lot closer to their extender and allied professional staff that are really the ones putting their hands on these patients and seeing what's going on outside of the practice walls. So the first thing I would always suggest to medical groups is to really start screening for social determinants now, and to make part of your patient assessment process to start asking some basic questions about social determinants. Do you feel safe in your own home? Do you feel like you have enough to eat? Or there are times in your life, maybe more than others, like at the end of the month, where you feel you don't have enough to eat? Things of that sort can really go an enormous way to helping us hotspot where the issues are, so that we can then target investment to where the need is greatest. I think doctors that talk very closely with their care managers about the trends that they're seeing the forest for the trees and what's going on with their enrolled patient base is critical, because those are the folks that are in effect the aggregators of what the nurses and everybody else below them are seeing. So they really can tell you about trends, about patterns that they're seeing in the patients that require intervention, or more than we can do to serve them within the four walls of the practice. And then once you've got a clearer picture of what that looks like, then working with the dominant insurers that represent most of your patient panels to say, hey, listen, we think if we did something around meal delivery, medically appropriate meal delivery for these 1,000 uncontrolled diabetics, and look at the electronic records we've got on these 1,000 diabetics, we think we could drop their cost by 25 grand a year. That's, 10x what we'd be paying for these meals. What would you guys say around to a program like that? That's where the magic starts happening. I mean, it's not lost on us, Ned, that right now at the insurance industry level, there's an arms race going on in social determinants. And a lot of the payers are awakening to the fact that only by investing in these types of social services and non-clinical interventions are we going to be able to bend the curve on what we're spending on these populations. I mean, just yesterday, United announced they're going to invest another $100 million into housing supports for their members in a couple of their states. So you see United, you see Kaiser investing $400 million in housing. You see whole transactions like Centene and WellCare, or Molina and Magellan being driven by not just market presence, but their capabilities in managing social determinants of health. I mean, these are fundamental kind of critical infrastructures now for insurers. They've awakened to it. I think as doctors get better at understanding the needs in their enrolled populations, and by the way, doctors get bolder about taking risk and going to value-based contracts, knowing this kind of information about your enrolled population is critical. You can't possibly manage to a value-based contract or to a capitation if you don't have a real robust picture of what's going on among your enrolled patients. So I think, the greatest emphasis right now is to encourage docs and to support docs in identifying these needs better, and then giving them the resources and programs that they need. I don't think we should delude ourselves that busy PCPs seeing 40 patients a day have any interest or time to manage this stuff that's going on outside their four walls. And so that's where third parties like us and insurers and joint ventures are really going to have to play a very important role in executing on these types of interventions.
I think that's extremely important. Like give them the opportunity to have a voice, to understand why they should have a voice to those insurers, and go, hey, this is what my panel looks like. Here's the data to support that, why we need X, Y, and Z. And I think that's super important.
Exactly.
So, John, I think that's an awesome place to end, because you have given a ton of value to the listeners.
It's my pleasure.
I want to ask you before we go, because I always want to end on the most positive note potentially that we could, is really, what are you most excited about when it comes to the future of healthcare?
I mean, look, I'm a hammer looking for a nail. So I'm most excited about the awakening that's occurred in the industry in this last couple of years, and that is intensifying, that social determinants really is where the focus needs to be if we want to bend the curve on what we're spending on healthcare. We have seen just this consistent escalation in medical inflation because we do a lousy job of chronic care against the backdrop of poverty. Again, thinking back to Maslow's hierarchy, if people's basic human needs aren't getting met, they're never going to be compliant patients. And if, the vast majority of our healthcare expenditures are consumed in chronic conditions, and the most expensive among those patients are low income with comorbidities and complex healthcare issues, then we have to deal with basic human needs in order to get them to help themselves. And so I think, insurers realizing that they have a role in directly addressing poverty and its effects within healthcare, to me, that's the beginning of what could be a real new age dawning around real population health that doesn't just look myopically through what clinical needs are, but the social needs that drive, as we said at the top, Ned, 60 to 80% of what we spend on healthcare. That stuff that gets me hot. Just thinking about how far we've come in just the last couple of years as an industry.
It is really cool to watch that. And it's awesome to see you at the forefront, really,
Thanks.
shouting from the rooftops about it. And, with that being said, where can people find you, track you? Where are you, where are you most screaming this from the rooftops?
Well, I'm pretty active on Twitter, but my Twitter feed is a little more unmuzzled.
That's my favorite feed. I'll be honest. I enjoy that feed.
I'm John Gorman 18, and I will warn, I am a bit of a reactionary, and I absolutely hate Trump and all of his Republican enablers, and I think they're killing this country, and you'll see a lot of polemics on my Twitter. My LinkedIn feed, though, is really where we talk a lot most about the work we're doing at Nightingale, and you can find us at nightingalepartners.org as well. Awesome.
And I will say to all of our listeners, they should go to nightingalepartners.org. It's a wealth of information. And not just information, but actual case studies to back this. So if you're listening to this and you're like, I'm not 100% bought in, just go to the website. You'll be bought in.
There's a ton of research there that just shows definitively that, this is the path.
Yeah, absolutely. So John, man, I really appreciate you hopping on and spending the time. Absolutely.
Pleasure, Ned. Thanks.
See you, bud. Bye.
Talk to you again soon.
See you, bud.